Next up, I am excited to introduce two leaders in the field of innovation, Michael McShea from the Johns Hopkins Applied Physics Lab and Dr. David Classen from the University of Utah and Pascal Metrics. Both David and Michael have been working closely with the Jewish Healthcare Foundation as it forms a national patient and provider safety authority. Today, they will explore how technology can make healthcare safer for all.
Thanks so much. Yeah, it's great to be with you, and hats off to the organizers. I never would have expected that you would have so many songs in your soundtrack off the theme of Liftoff here. But it's been a wonderful event, and we're very happy to be here to talk about a very important area of innovation for healthcare, and that is in the whole realm of patient safety. And so we're going to talk you through some really things I think you'll find interesting, and hopefully get the discussion started. And I know there's some exciting announcements coming up as well. But I'll start with just a couple of words and then hand it off to David for some incredible things that are going on right now using data and patient safety. But just to start with, just to kind of set the stage a little bit, patient safety has been at the forefront of a concern and issues with the healthcare system for many years. To err as human is more than 20 years old. But what's happened since then is the entire healthcare infrastructure has been digitized thanks to the HITECH Act and EHR adoption. And so much as you heard about earlier with Verily, there is so much data out there. The opportunity created by that data is substantial. And together with data science and cloud computing, we really stand kind of at the start of a decade of how we can use that data to more effectively deliver healthcare and how we can do it more safely as other industries have. And so we've been talking about automation and AI together because that's an area of healthcare innovation that is really lagging other industries. But I'll hand it over to Dr. Classen next, and he'll tell you about some things that are already happening. And then we'll get back to where's this all headed.
Thanks
David?
very much, Michael, and it's a real pleasure to be here. I'm going to summarize an operational program that actually has leveraged the technology platform that's been established that Michael's talked about to actually measure safety in real time, predict safety problems before they occur, and lead to market reduction in harm. So I'm going to try to share my screen here, and Michael, you can let me know if it's working. And can you see this, Michael?
Yes.
I hope. Great. So Michael's exactly right. We've built through the broad adoption of electronic health records and other health information technology, a platform that can be used to fundamentally change how we manage safety, moving from a retrospective approach in safety to a real-time and even a predictive approach. And that platform exists with current technology of electronic health records and with the current state of interoperability. And because that platform exists, Don Berwick and I and Fran Griffin wrote an editorial about 2 years ago. It said, it's time to move on from measuring and managing safety with our manual and retrospective methods and start adopting this new technology we've created to measure safety in real time when we can really make a difference. And this particular approach was summarized in an operational program that's running in more than 100 hospitals in the United States and Australia using current vendor platforms, Cerner, Epic, Meditech, Allscripts, using current interoperability. And that program has been able to automate patient safety so we can measure it in real time and predict it before it occurs, and use that not only to improve our understanding of safety problems, to markedly decrease the occurrence of harm. Hospitals that have put this program in have compared how many safety problems they detect with their current systems, about 147 here, and look how much more they detect when they automate patient safety measurement using currently available technology. So we're talking about 25x. And that's a real game changer because most organizations never had enough safety information other than to do a lot of root cause analyses on less than 5% of all the safety events. So this is a mark forward. You can do this with currently existing technology. And this allows, and this is real world data from an organization that's using this type of system, for them to finally identify all harm and begin to reduce it over time. And I do believe, as Don Berwick and I said, we'll never get to this level of improvement safety if we're using systems that pick up 5 to 10% of the safety problems and pick them all up retrospectively through voluntary reporting or through coding. And we can go further with this data, as the article outlined, and actually use artificial intelligence techniques to create predictive algorithms that can predict safety problems before they occur. This is a real world case, but the dates have all been changed. And it was a patient who came into the hospital with an acute abdomen, initially was measured with this global safety risk predictor. It's a artificial intelligence program that harvests all this data from the EHRs, uses it to predict harm and predict risk of harm. And basically what happened is this patient came in, underwent surgery, and then as the hospitalization went on, they started having a rising safety risk score. And then they went on to develop an abscess, and then they went on to develop bleeds. And if you look down here at all the predictors, you can see at any point in time where they're going. So the bottom line is we can now, with currently available data, predict safety problems up to 3 days before they occur. The Robert Wood Johnson group said, why are we just giving this information to healthcare providers? Why don't we turn around and give this information to patients and families directly as a part of their care? So they funded a project we did where we took all this information I've previously shown you, showed it all to patients and said to patients, why don't you redesign this dashboard in a way that would be friendly and usable to you, your family, and your caregivers? And we'll make this a part of your hospital care. So we did just that. And this is what patients came up with. This is not what I would have designed, but this is what patients wanted to see. First, they wanted to see a risk score across the continuum of care of safety problems. They wanted to know whether they're inpatient, outpatient, at home, what's their risk of having a safety problem at any given time. And if they're in the hospital, they could click on this little button here, and not only would give them their safety score, but it would show them exactly what their safety problems were at that time. And here's an example of this, is a real world case. Patient had positive test for bacteria in the urine. The patients then want to know, what questions can I ask my healthcare provider about this specific problem? What things can I do to deal with this problem? And where can I get more information? And we built about 45 of these little safety problems and gave it to patients. And patients were insistent that we give this to them on any platform. So it would work on their desktop, it would work on their laptop, it would work on their iPad, and they even wanted it to work on their phone. Why did they want it to work on their phone? So family members who were not in the hospital could gain access to this information and watch a loved one from afar in terms of real-time safety information. So we tested this in a trial, and what did we find? We found that patients who had access to this information, number one, had lower 30-day readmissions, lower 30-day mortality. We also found that if they had access to this, it increased their patient activation metric. That's a score of how engaged patients are in their care. But we also looked at secondary outcomes. We were worried this would scare patients. Turned out we measured that it didn't. We were worried patients wouldn't be accepting of this or found it value. It did. And then we learned that patients love the idea of being able to access information with their care providers and their families outside of the hospitals. So with that, I will turn it back to Michael and stop sharing my screen. Michael, it's all yours.
Thanks, Dave. Stepping back, I mean, I think that what's wonderful about the applications that Dr. Classen is talking about is using data to drive up patient safety, not only putting that data in the hands of the clinicians that are delivering care to prevent harms, but also the patients. And so it's just a really wonderful example of how to apply data in this space. I also want to just acknowledge that there's all kinds of wonderful things going on with data, and you heard about them throughout the day today, I think, and Verily comes to mind in particular. There's incredible things going on with data, whether it's precision medicine or population health with new machine learning algorithms to risk stratify and identify patient phenotypes. AI is here with healthcare, but I think what we're talking about in this segment is a little bit different than just AI. It is how do you put that data to work to create more intelligent systems. And I'm sharing with you the AI roadmap that was produced by the Intelligent Systems Center at Johns Hopkins Applied Physics Lab. For those of you that don't know much about APL, APL is actually a part of Johns Hopkins University that's separate from the university or the health system. We work very closely with the health system, obviously, of my particular group, which is the National Health Mission area. But we do AI applications and intelligent systems as a matter of core expertise across the whole lab. And so this particular AI roadmap is really trying to map out vectors of innovation for building more intelligent systems. And so I wanted to highlight just a couple of things and hopefully get you thinking about the kinds of innovation that you can bring into your healthcare applications along these lines. First, though, to point out where we are today is in this bottom left kernel here, pattern recognition. And as the diagram shows, there's much room for much more advanced applications of data than just that. But I would say that this next layer is really where Dr. Classen's application comes into play, and where more point of care based solutions come into play, where you have more machines basically understanding the context that they're operating in, bringing data together in a way that's relevant to the clinician at any given point in time, allowing that clinician to make decisions that they would otherwise make differently or not be able to make. And so essentially what I'm describing here is not just autonomous perception or decision making or decision tools, but actually human machine teaming. And I think this is a really important way to look at the problem we're trying to solve here. You're not removing the patient or the clinician from the actual act of care delivery. You're in fact teaming with those humans, with the machines and the intelligence that you can bring to bear on that problem. And so as we look at this roadmap, I think some of the things here are recognizable. Certainly you can think of other industries and aviation related analogies are kind of a bit tired, but I'll use it anyway. Autopilot and things of that nature have been around for a long, long time, decades. When you think of automation and telecommunications and cybersecurity, these applications are out there, and mission critical systems are being built that have intelligence and increasingly turn over more and more responsibility for the operations to computers. But I want everyone to think even a little closer term, though, that we can actually build applications that integrate with care delivery and bring automation to healthcare without going all the way to robotic assisted surgery and advanced applications like that, although they're very exciting. But I think that there's much more opportunity in the short term that we could address with AI if we start thinking of how to make the systems of care delivery more intelligent. The one last piece I'll highlight here, and then I'll talk about just a few interesting applications that hopefully will orient you that yes, in fact, real autonomous care is possible and in our future. I want to highlight just a little bit the safe and assured operation. And this is really critical. I think that anyone innovating in healthcare today knows that it's not just enough to create superhuman decision-making algorithms unless clinicians will trust those algorithms. And so it's really critically important at every stage along the way in the roadmap here to consider the safe and assured operation. It's not just for robotic assisted surgery that's important. It's important at every point in the care delivery process, from diagnosis through treatment. I'll highlight just one more thing on this diagram, and you see the near, mid, and far term timeframes down here. When we're thinking about some of these things, teaming at the speed of thought, and in fact, we do mean at the speed of thought there. APL does some work with brain-computer interfaces. In fact, we're talking about more and more autonomy with systems and less intervention by clinicians. And think of this also as more and more in the hands of patients with digital tools and that sort of thing. The AI and the assured and safe operation is as important in that scenario. But in the near term here, we're talking in the next 1 to 3 years. And so these are things that are already happening and advancing in other industries that healthcare is really, really ripe for. In the midterm, we're talking in the 3 to 10 year time frame, and in the far term, we're talking beyond 10 years. So these kinds of developments are not that far in the future. And think about it, it was only 10 years ago that, in fact, a little over 10 years ago that high tech started digitizing healthcare. I'll just highlight one more thing that'll help maybe punctuate the point that we're actually not that far off from more applications that bring more autonomy. Just highlighting the medical device interoperability reference architecture, we affectionately call Madeira, is a program that APL is working with the Army Medical Research Development Center and TATRIC, which I'm sure is an organization that is something they're all familiar with. You may have heard about if you're in telemedicine or any of those technology spaces. This is actually a program that's looking long-term to actually deliver autonomous care in the field to soldiers. And that's an actual very real need with potential mass casualty events with peer adversaries without communications superiority or air superiority. And so really the ability to autonomously care for patients, soldiers in the field for periods of 72 hours and even longer requires that you create capabilities for the medic that are beyond their current capabilities. So think superhuman again. And you also create capacity, and that is the ability for a medic to take care of mass amount of casualties. That can't happen without automation. I'll bring it just a little bit closer to term, and that is with another program related to this that we're working with TATRIC called the National Emergency Telecritical Care Network, which really is looking to create capabilities for telecritical care along these same lines. And so think about the current COVID crisis, think about ICUs filling up, think about not having enough clinicians to attend to the swell of patients, and things like autonomous ventilator control, autonomous infusion pump control, and things of that nature are desperately needed to expand the capacity of our healthcare delivery. And it can be done safely. And I think that, sometime in the future, as you see in the picture here, there will be actually, robotic assisted point of care ultrasound and other applications along those lines as well. So I think that, standardizing care delivery is at the root of this, but so is data, and so is more intelligent systems. And I think this focus on the patient noted here, and Dr. Classen mentioned it as well, critically important to keep the patient at the center of this and keep care safe, but make it safer with this technology. So I'll hand it, David, maybe back to you to comment a little further about the things you're doing.
Thanks, Michael. I think what's very interesting about the process when we designed that real-time dashboard for patients, families, and caregivers to use, it looked nothing like what we would have designed. It looked nothing like what we give to healthcare workers. And as we were designing it, the patient said to us, please don't use this system to replace us. Use this system to support us. I think that's a lesson we've learned with frontline clinicians as well. Because the patient said to us, look, when we leave the hospital, if you think there's somebody watching over us from the healthcare system all the time, you're sadly mistaken. So designing a system that someone else employs to watch us and manage us is not the way care works. We're on our own when we leave the hospital for the most part. So design a system that supports us and works for us. And that's in essence what we created. But it harks back to the lessons we've learned when we want healthcare providers to use these systems as well. Healthcare providers have told us again and again, I'm not going to use it if you design a system that's going to replace me. I want you to design a system that will support me, support my decisions, support my care of the patient rather than replacing me. And I do think there's a bit of fantastical thinking with artificial intelligence that we're going to have the self-driving doctor like we have the self-driving car or the self-driving patient empowered by artificial intelligence approaches. I think, as we've learned with healthcare providers and now with healthcare patients, the self-driving anything is not going to be the model that works, and certainly not the model, as Michael says, that will lead to trust on the part of either the clinician or the patient in their care. So I think we've learned that over and over again. And just one anecdote, as we were designing that dashboard for patients, the question came up in our patient focus groups: what if your doctor told you not to trust or not to use this system? What would you do? And I can tell you, 75% of the patients said, and this shocked me, we'll get a new doctor. Whereas 25 years ago, I think most patients would have said, if my doctor tells me not to use the system, I'm not getting anywhere near it. And so I do think we are seeing, as part of the evolution going on, not just a technology evolution, but an evolution of patients unwilling to just accept advice from someone else, whether it be a human or a computer. So Michael, you might want to react to that.
No, I think you're spot on, David. And I think that keeping the patient and the clinician in mind and keep thinking of it as teaming with intelligent systems is the right way to think about it. Now, I do think that, you bring up a really good point though, and that is that most of the time we are not with our care providers. And so as care pushes outside the hospital, the safety of the patient is critically, I think, supported by additional digital health tools and intelligent systems through digital apps and things of that nature, but not without trust. I think that's really important for everyone to keep in mind.
And so we measured trust in that Robert Wood Johnson project I mentioned, and it turned out to be a really critical factor in terms of whether patients would take the advice that the system generated for them.
And I think that, that we see, with COVID, and the relaxation of a lot of regulation, we see a lot more virtual and digital health coming into play. Patients are getting more and more used to that kind of mode of operating. Increasingly though, intelligent systems in our health apps are going to help us keep healthy and increasingly give us advice on an ongoing basis that we need to trust to change our behavior. So I think, I hope that you'll think about these concepts. I hope they inspire some innovative approaches to things and really do appreciate the ability to address you in the event today.
And one other issue, Michael, that comes up again and again, we have the technological infrastructure to make what I showed come true and to make what you showed come true, yet its adoption is really quite limited so far. That's the reason Don Berwick and I wrote the editorial, which is, why would you spend so much money on all these EHRs and still be managing safety retrospectively with 40-year-old systems?
That's exactly right. I think, the regulatory environment is very ripe for, really attacking this problem and using this data in ways that has not been used before. And I think that all the work that's been done in interoperability of data, while there's still a lot of work to do, is also helping to make this more possible.
And the interoperability's gotten to the point that the program I showed you is currently operational and available with all the leading EHR vendors. So, I think the perfect is the enemy of the good. Waiting until we have complete interoperability is probably not going to be a wise choice. We can do a lot. We can do everything I showed you right now with current level of technology. My question is, what do you think will be a big driver in broader adoption of this technology to really revolutionize the way we manage safety?
Yeah, I think healthcare is definitely the space where it's going to happen. And as you said, the data's there, but we're at the very, very early stages of adoption. So what better topic to talk about at today's event? Hopefully you've got some inspiration and some ideas out of this discussion.
And so, Michael, I was thinking that, do we think that it's going to be patient demand for these systems that leads to adoption, or do we think it's going to be regulatory changes, or both?
Yeah, that's a great question, David. And I think the answer the answer is both. Before COVID, I would have said that it would be consumer demand that really drove this change because the industry is slow to change. We now have consumer demand together with, an environment that is very, very conducive for innovation in this space and with data and healthcare. So it's the planets are aligned to take it back to the liftoff analogy.
Yep. Yep. And so, what initiatives do you think might actually help that? Clearly, broad dissemination of the patient access to this information would probably be critical, but other initiatives you think might be helpful in really driving this forward?
Very good. So it's been a pleasure to address you all today. Look forward to the rest of the events of today, and I will hand it back to the moderator.
Thanks very much, Michael.